Good day, everyone. I am Singh, and today I will be presenting two important but often overlooked categories under depressive disorders in the DSM-5-TR. The other specified depressive disorder, or the OSDD, and the unspecified depressive disorder, or the UDD. So, most of us think of depression only in terms of major depressive disorder or persistent depressive disorder, but not all patients neatly fit those definitions. These two categories, the OSDD and the UDD, give clinician the flexibility to recognize depressive symptoms that are real and impairing even if they don't meet the full textbook criteria. So in this report, we'll cover their definition, key differences, clinical examples, assessment, differential diagnosis, prognosis, and treatment. But before we dive into the details, let me share the learning outcomes for this session. First, by the end of the presentation, you should be able to differentiate between the OSDD and the unspecified depressive disorder, or the UDD. Second, you'll be able to apply your knowledge by recognizing real life examples or clinical vignettes. For instance, you'll know when to call a case OSDD, short duration episode, versus when to use UDD in an emergency setting. And third, you'll recognize why accurate documentation and treatment planning matter when using this diagnosis. These categories may sound vague, but they are clinically important because they guide how we monitor patients, communicate with other healthcare providers, and plan treatment interventions. So, in short, by the end, you should be able to distinguish, apply, and appreciate the clinical value of these two categories. Now, let's begin by defining what is OSDD. So, other specified depressive disorder, or OSDD, is diagnosed when depressive symptoms cause distress or impairment but do not fully meet the criteria for any specific depressive disorder. The key feature is that the clinician specifies the reason why the criteria are not met. For example, the episode might be too short in duration, or the patient may have too few symptoms. So the diagnosis might be written as OSDD, short duration depressive episode. This way, the symptoms are acknowledged and the clinical reasoning is clear. Now let's proceed to the common presentation of OSDD. So the DSM-5-TR gives examples of situations where this diagnosis can be applied. First is the recurrent brief depression, which is a depressive episodes lasting 2 to 13 days, occurring repeatedly. Then the short duration depressive episode, which lasts 14 to 13 days, which is less than the 2-week minimum for major depressive disorder. We also have depressive episode with insufficient symptoms, where a person has only 2 or 3 symptoms, such as low energy, insomnia, or hopelessness, but not the required 5 symptoms. These examples shows that depression can present in different ways, and these categories make sure those cases are not ignored. Now that we know what OSDD is, let's now proceed to the unspecified depressive disorder. So, what is UDD? So, unspecified depressive disorder, or UDD, also applies when depressive symptoms are clinically significant, but in this case, the clinician does not specify the reason why the criteria are not met. This diagnosis is especially useful in emergency or urgent care settings where there may not be enough time or information for a full evaluation. For instance, if a patient comes into the ER with crying, insomnia, and hopelessness, but the clinician cannot yet determine the duration or number of symptoms, they can use unspecified depressive disorder, or UDD, to document the case. Now, when is it used? Unspecified depressive disorder or UDD is most often used when, first, the clinician doesn't have enough information to give a more specific diagnosis, or the setting doesn't allow for detailed assessment, such as in the ER or during a crisis intervention, or there is uncertainty about whether symptoms are caused by medical conditions or substances. In these cases, this category acts as a placeholder, allowing the clinician to document the depressive symptoms and continue gathering more information. Now let's talk about the key difference between OSDD and UDD. The main difference between these two categories is in OSDD, the clinician explains why the patient does not meet full criteria, while in UDD, the clinician does not give a reason, often because there is not enough information. So the difference depends on the level of clinical detail available. Both are valid and serve the same purpose, and that is to ensure patients are not left undiagnosed. And now let's talk about assessment. When assessing these cases, clinicians follow several steps. First is a psychiatric interview to gather details on symptoms, duration, and severity. Then they use rating scales such as the PHQ-9 to measure depressive symptoms. Also, they collect collateral information from family or teachers if available. They also use a medical workup to rule out conditions like thyroid problems. In addition, they also do substance use screening since drugs and alcohol can mimic depression. And on top of it all, they do a suicide risk assessment, which is always a priority. At the end of the evaluation, the clinician documents whether the case is OSDD or UDD. But before confirming the diagnosis, clinicians also rule out other possible conditions like major depressive disorder or persistent depressive disorder, bipolar disorder, adjustment disorder with depressed mood, medical conditions, or overlaps with anxiety disorder, and so on and so forth. So this process ensures that the diagnosis is accurate, which is critical for effective treatment. So in research, these two categories are not often studied separately, so we don't have precise prevalence rates. Most studies focus on major depressive disorder, but in everyday clinical practice, OSDD and UDD are commonly used. They reflect the reality that many patients present with symptoms that don't fit perfectly into standard categories. So now let's talk about the course and prognosis of these disorders. The course of these disorders varies. Some people recover on their own, some experience chronic symptoms, and others may eventually progress to major depressive disorder. While its prognosis depends on factors such as symptom severity, comorbidities, psychosocial stressors, and whether treatment is available. This is why early recognition and proper follow up are so important to prevent worsening of symptoms and to reduce suicide risk. Now let's talk about its treatment principles. So one of the main approaches for managing OSDD or UDD is psychotherapy, especially when symptoms are mild to moderate. The most common and evidence based form is cognitive behavioral therapy or CBT, which helps patients identify negative thought patterns and replace them with healthier coping skills. Another option is interpersonal therapy or IPT, which focuses on resolving relationship issues and improving communication. For some patients, supportive therapy, which provides validation, encouragement, and problem solving, is also helpful. Psychotherapy not only reduces current symptoms but also strengthens resilience and lowers the risk of relapse in the future. While when symptoms are more severe or significantly impairing daily life, medication may be needed. The most common are SSRIs or selective serotonin reuptake inhibitors such as sertraline. These are generally safe, well studied, and effective. Other classes like SNRIs or atypical antidepressants can be used if SSRIs are not effective or tolerated. It's very important to monitor patients closely during the first few weeks of treatment, not only for side effects, but also for any changes in suicide risk. In many cases, the best result come from combining pharmacotherapy with psychotherapy, giving patients both biological and psychological support. A third principle is psychoeducation and lifestyle support. Psychoeducation means helping patients and families understand what depression is, why treatment is important, and what the prognosis may be. This reduces stigma, increases motivation, and encourages treatment adherence. Lifestyle changes are equally important. Regular exercise, a healthy diet, and consistent sleep patterns all improve mood regulation. Stress management strategies such as mindfulness or relaxation exercises help reduces triggers. Finally, building and maintaining a strong social support system makes recovery more sustainable. These everyday strategies may look simple, but research consistently shows that they make a significant difference in recovery and prevention of relapse. Now, here are two short vignettes and how we would apply the diagnostic rules of OSDD and UDD. Vignette 1: a 28-year-old woman reports recurrent episode of low mood, social withdrawal, and fatigue lasting 5 to 8 days, occurring several times a year for 2 years. During these episodes, she has about 4 depressive symptoms and misses work due to low energy. She does not meet the 2 week duration required for a major depressive episode, but the pattern is recurrent and causes impairment. Because we can name the reason, which is short recurrent episode, the appropriate diagnosis is OSDD, recurrent brief depression. In the chart note, you would list the symptoms present during episodes, the typical duration, how often they occur, and the functional impact. Management would include psychoeducation, consideration of psychotherapies, safety assessment, and scheduling follow-up to monitor for escalation into a full major depressive episode. While Vignette 2, a 60-year-old man is brought to the ER by ambulance for low mood, insomnia, and appetite loss. This is very limited history, no collateral, and lab work is pending. He is clearly symptomatic, but we cannot determine symptoms duration, prior episodes, or medical contributors yet. In this situation, we document unspecified depressive disorder or UDD with a clear statement that the diagnosis is provisional due to insufficient information. Immediate tasks are to perform a focused medical and toxicology screen, assess suicide risk, stabilize as needed, and arrange prompt outpatient or inpatient reassessment once more data are available. These two examples show the practical differences of OSDD and UDD. When you can state why the criteria are not met, use OSDD. When you cannot, use UDD, but always document reasoning and next steps. Overall, both of these diagnoses serve as a safety net, ensuring that patients with significant depressive symptoms are not ignored or left undocumented. They remind us that even when symptoms don't meet textbook definitions, they can still cause real suffering and impairment. Ultimately, recognizing and accurately using these categories is essential for proper documentation, guiding treatment, and providing the best possible care to patients. So that would be all. Thank you for listening, and I hope this presentation gave you a clearer understanding of these two important categories of depressive disorders.